Good evening, everyone. Again, my name is Lisa Payton Kerr, founder and president of a small but very able nonprofit organization called the Foundation for Black Women's Wellness. We were established in 2012, so we're entering our 6th year of work here, based in Dane County. Our work began 10 years ago with the creation of an event actually called Black Women's Wellness Day. And I'm giving you this background for a reason. Black Women's Wellness Day is an annual health summit that we host here now in Dane County every September to really pull Black women, health partners, systems, community organizations together to talk about, celebrate, and create solutions for improving Black women's health. And I started that event 10 years ago when I was living yet on the East Coast, 2 years after the death of my mother, Roberta Payton, at the age of 64 from congestive heart failure, which is a condition that progressed for her starting at the age of 48 when she had her first heart attack on her way to work at her small beauty parlor, the Beauty Hut in Richmond, Virginia, where she raised her family, provided for her immediate family and extended family over the course of her life right after high school until she died. That experience of watching my mother die and progressively get more sick over time as a self-employed woman, divorced single mom who could not afford the cost of health insurance consistently. So I grew up as an uninsured child with some dental care because she really felt strongly about teeth and dental care and fought to pay for a small policy so we could get annual cleanings. But health care was not something we had the privilege of having consistently because of cost. And my mother and all of her siblings and my grandparents, there was no such thing as regular health care growing up. I think my mother saw a community doctor as a young woman, as a girl. And I remember seeing that same doctor when I was a little girl. We lived in a rural area. So I feel very sensitive to what you talked about, Donna, because I grew up in a rural community, but I work and live in an urban, suburban community now. So my life has been impacted by all of those dynamics. And it's vitally important that when we talk about health care access, disparities, quality of health, that we do merge the two conversations of urban, suburban, rural, because it's one conversation. And the stronger that conversation will be if we come together across false barriers, false lines, to have that conversation collectively and to create solutions together. So I saw all these dynamics at play. And in rolling back and looking at my mother's life and kind of assessing what had happened to her, I realized that what happened to her, dying early in the prime of life at 64, had happened to dozens and dozens of other women in my immediate family and community and in that hairdresser that I grew up in as a shampoo girl for most of my life. After my mother died, I actually took up a pad and paper after we got through her wake, her funeral, months of grieving, a year or so of intense grieving, and then I just had to face myself and say, this isn't finished. My mother's experience and story is speaking strongly to me, and in looking out and writing those names down and remembering that what I had gone through with my mother, I had gone through many times before. I had attended many, many funerals of Black women in their 50s, sometimes their mid-40s, occasionally their late 30s, most usually in their early to mid-50s and 60s. I would get the calls as the shampoo girl in the back of the beauty parlor with my mom working at the front in her chair, her partner next, her business partner. And the phone would ring and a customer would say, Lisa, is your mom busy? I need to speak to Roberta right now. And I would say, oh, can't speak to her right now. She's working on a customer. Can I take a message? Well, when she takes a break and she sits down, I want you to tell her that Doris died this morning. Her children found her in the bathroom on the floor after she got off from third shift working at the Philip Morris cigarette factory. She had a stroke. massive stroke. She's gone. We just saw her in the shop 2 weeks ago. She just got a press and curl, and I put black rinse on her hair, and she likes it to sit really long so it covers all the gray between appointments. And that conversation and that occurrence happened more frequently than you can imagine. So as I wrote this pen and paper, took my pen and paper and wrote these names after my mother's death and came down to about 60 names of real women whose heads my hands had been in to shampoo just the way they liked it, whose funerals we attended, or whose phone calls we received about their passing. I knew then that I couldn't go back to just doing and being as I was before. And so this work evolved from that recognition of a pattern of black women dying young with no real national alarm bells sounding off about this phenomenon, which is far too common. So I offer my comments tonight from that perspective and not as a healthcare expert by any measure of the imagination. I'm so grateful that Donna and the Academy invited me to sit on a distinguished panel with Greg in a context of folks who do work that is at expert level around healthcare. But I come as an advocate, a passionate advocate, observer, and a community worker who really is an advocate for quality health care, affordable access for everyone, and particularly for black women and their families and their communities, and especially in the state of Wisconsin. On a regular basis, our organization works with and encounters women, family, and children who are uninsured, underinsured, and caught up in the toxic cycle of disparity and poor health outcomes that have been well documented in studies and reports like Race to Equity. Annie Casey Foundation has reported on it, extensive. And I'll tell you, I've lived in Madison twice. My husband's born and raised here. I moved here first with him in 1993 through 2001, came back 6 years ago, and we're still talking about the same disparities and gaps. They haven't changed a lot. And so the women and the families that I worked with in my early career in the social services arena and community-based nonprofits, I've come back to encounter those same dynamics in full swing. And so thinking about disparities and gaps and how they persist here and asking why is critically important. For these women and their families, like all Americans, access to health insurance and quality health care is critically important. It's part of the American dream of securing that we really underestimate. And for black women and families, it's really a matter of life and death. It is no simpler than that, or no less complicated than that. It is a matter of life and death. This is critical for us to understand in the context of current realities here in our own state, where we lead the nation in health and quality of life disparities for black men, women, and children. And I say that to say this is a very proud state. This is a very progressive state. There is so much to be proud of. We live here in this city with a Big Ten university and one of the most progressive, innovative places, not only in the country, but around the globe. We really are a trendsetter. So the question is asked, why then do we trail among 50 states in health quality and outcomes for African American women, families, and children? It's unacceptable, but we have every resource that we need to fix that. And I think that we will get there. What we know today is that in Wisconsin and Dane County, black women are more likely to be, as I said, uninsured or underinsured, which curbs our collective access to preventative care and timely treatment for chronic illnesses. We are more likely to live and die from largely treatable and preventable illnesses. Black women are more likely to live in poverty and much higher rates than their white counterparts, despite the fact that 8 of 10 women work and are employed, contrary to public perception. And I remember when I lived here the first time, And throughout our culture and our history, the image of the Black welfare queen who sits at home all day and collects all types of aid and isn't interested in working, I will tell you that is a false narrative and a false image that we all need to shut from our psyches. Black women are employed and working at higher rates than other women in our county. We're more likely to die of heart disease, cancer, stroke at higher rates and at younger ages. More likely, specifically in Dane County, to die of breast cancer, which is the leading cause of death for Black women here in Dane County, and of more aggressive forms that are harder to treat and survive than our peers, and at younger ages, though we are less likely to be diagnosed with the disease, to know we have the disease because of barriers in healthcare access and quality of care. So by the time we find out, our condition is so progressed that treatment really doesn't work. We're more likely to give birth prematurely to low-weight babies who are at greater risk of dying in the first year of life, resulting in alarming infant mortality rates that had fell over a period of time and now are rising again. And I think it's at a rate of 2.5 to 3 times higher than white women. I think per 1,000 births, which is the measure of infant deaths per 1,000 births, 13 Black babies die per 1,000 births as opposed to 4 white babies. And 13% of women, Black women, give birth to low birth weight babies as opposed to 6% of white women. So we should be concerned about every woman who's given birth to low birth weight babies, but we should be really concerned about the gap in that experience and the occurrence of that phenomenon. We're 3 times more likely as Black women also to die in childbirth or shortly after childbirth than our peers. And there's been a lot of national attention to that issue. We're not seeing the increase in maternal mortality in Wisconsin like we're seeing in other states yet, and we don't want to see it. But in seeing rising levels elsewhere, we need to be concerned that we don't get to that point because of what we already know about the circumstance of our health outcomes for Black women in our state. And it doesn't matter that woman's education or income level. If she's a 6-figure PhD earning Black woman, she is still more likely to give birth to a low-weight birth baby or to die in childbirth than a white mother with just a high school diploma, regardless of her resources and her health care. And these poor health outcomes persist, as I said, regardless of income and education. In fact, we know, as I'm repeating myself because I'm reading notes with these glasses that don't really give me the bifocal qualities that I need. But these and other disparities persist here in Dane County and Wisconsin, where ironically Black women and families have greater access to health care than in many other states. Yet we still, as Black women, experience the worst overall health and mental health outcomes than any other group in our state. Why? And I'm not going to answer that question completely tonight, but all of that is compounded by what I call a complex web of social and economic inequities in employment, education, wealth accumulation over generations, the lack of housing, quality food access, and other factors commonly referred to as social determinants of health. The lack of these things, the shortage of these things, and the ecological experience that we have as we're navigating communities and all the factors that impact quality of life. These things disproportionately impact Black women and our families, seeming to trap Black women and men. So as I talk about Black women, it's a mirror image of what Black men are experiencing. So I really could say the Black family, but we talk about it specifically in our organization around Black women, and I'm proud of organizations like Aaron Perry's African American Men's Health Center and the Rebalanced Life Health Foundation in Dane County, who's our counterpart and working on these issues around African American men. But the community and everyone in it, leaving us trapped in an endless cycle of disadvantage, disparity, and poor health outcomes despite the massive resources that surround us every day. In fact, Black women in Dane County experience an average age of death of 60 years old in Dane County. And that number changes every year. My organization has been working with Public Health Madison Dane County for the past year. We recently published a small data brief to share with our stakeholders, and I'll make this available if folks want to share it out. And measuring that average age of death, it's calculated by the number of Black females who die each year in Dane County. So that number is pretty small. So let's say it's 50 deaths a year, and it includes any deaths from a baby, newborn, to however old that female is. But the averaging at 60, tells you that there's a lot of young people dying. That same average age of death for a white woman is in the 80s range. So there's a 20-year average age death difference between Black women and white women in Dane County. And that should be concerning. And the bigger concern is that this is up from an average age of death of 55. And over the last 25 years, that's the only real movement that one has seen. Because of these factors, our organization is committed to working in every way we can, not only to empower and move Black women personally toward better health outcomes through education and outreach, but to work with partners and systems to create solutions and joint efforts that systemically improve Black women's health, and with our eye on moving Wisconsin from the worst to the best for Black women's health. And we believe that when we do that, we will improve health for everyone, because what we've seen from Donna's presentation and from the remarks about rural communities is that when we invest in folks who struggle the most, it improves the outcomes for everyone, no matter where they sit demographically. It is also why the discussion of health and health insurance access and quality is of vital importance, especially here in Dane County in Wisconsin, where African American women, men, children, families, and our sickest and most economically distressed citizens and communities stand to lose the most. And I'll leave my comments there as we go into further discussion together. Thank you.
Grading now. Okay.
That's high.
So I hope we've given you all something to think about. I would like to invite questions from the audience, and if people are not going to come forth, I'm going to start asking questions, and I think you've already heard a lot from me. So please, I welcome your questions. Yes.
I notice you don't have a physician on your panel. Is there a reason for that?
No, it was definitely not a deliberate decision. But no, absolutely was not a deliberate decision. If we were going to invite a particular health professional, I wouldn't specifically choose a physician versus a nurse practitioner versus any other particular kind of healthcare provider, because there's many wonderful healthcare providers. But I think we wanted to try to address the issue of equity for rural and urban areas. And so we tried to give different voices in that matter. But there are many physicians and nurses and physician assistants and dentists and others who can also speak to this in their own way. Yes.
You didn't mention mental health. You didn't mention drugs. Certainly both are very much in the news. Where do we stand, rural versus city?
Yeah.
I can address that. Donna showed you some health profession shortage areas for primary care and for dental. Mental health is as bad or worse. And so geography matters. There, I would say we obviously don't have enough mental health providers of all types to meet the needs of people in our state. And the opioid epidemic, or in the north or the western side of the state, methamphetamines that's being manufactured elsewhere and brought into the state, is devastating rural communities. And we know that that exists in the urban areas as well. And so our state legislature has been very active over the last several sessions and it's been a pure, I believe the first HOPE legislation was 99-0, and they basically said we're going to start with the northern tier of counties across from the northeast to the northwest. And one of the saddest things that I think I experienced is I went up, this is Price, Iron, Vilas, Oneida, and Forest counties. That was the central area. And I convened all the providers of services, of which there are not enough, and the human service agencies. And we all sat down and we said, you know, is there a need? And yeah, there's a desperate need. Well, the state understands that. They put out a grant opportunity. It was $3.2 million over 5 years to stand up treatment resources. Who's going to apply? No one. No one has the ability to apply. You know, the human service agencies was being lobbied by the state. Come on, you got to come in. And so in our meeting, they turned to me as the community health center director and said, can you do it? Can you apply? And I said, well, at the time, we didn't even have addiction treatment services, but everybody agreed there was a need. So what we said was, we will apply. We'll get the grant done. We have that kind of expertise. But if we're going to do this, we're going to do it together. And so we wrote it as a consortium grant. And I had a colleague, health center in the Northwest, went through the same thing. Nobody was going to apply. So I mean, what's sadder than that? The communities have are being torn apart by this. And and the legislature recognizes they provide resources. And it was very hard to get people to compete for this. And we need to be asking ourselves, why is that? And they came back the next time with what I call HOPE 2, and they prioritized another whole set of counties. And we got more. So the legislature is actually doing its part in trying to get resources to the highest priority counties, but it's a slow process, and we're going to run into a situation where even money isn't enough, because if we don't have highly qualified providers, the money isn't going to do us any good. So we have to work on all those fronts, the workforce front, as well as treatment, money to help for treatment. And you know, we're sitting there, we heard a lot from employers up north, and I think the governor heard the same thing. If you want to help the employers, which is key to getting people jobs and getting us back on the right track, send us some workers who can pass a drug test. Well, where's the role of the health system? You know, if you want a job and your addiction is keeping you from it, that's an opportunity from a healthcare perspective to intervene and say, we'll help you get rid of that thing that's barring you from your goal of getting a job. But they don't have insurance, they don't have a job. Who's going to take care of them? These dollars that the state legislature and the governor have supported is part of the story on how we can get around that speed bump and get that care to those folks and get them back in the job market and help our employers and then help economic development. I mean, we got to all work together. It does all fit together if this is going to work.
I'll just add to that briefly that yes, we are absolutely feeling the shortage of adequate mental health services here. Of course, drug treatment, there never is enough room to accommodate the need and the demand for those services. We also see mental health providers struggling to provide the care because I believe the reimbursement rate through Medicaid, I think it only covers a portion of the costs of mental health services. So that's something that we see for folks who are largely low-income populations of people who are experiencing, not exclusively, but we see mostly here a critical need of families who are struggling economically, whose mental health is impacted by the state of being low income and all the stressors and the pressures that come along with that, that literally impact your mental health and your ability to cope. And then we also see, as a consequence of having mental health challenges, how it impacts people's ability to function and be stable in their lives. So it generates economic challenges. And those folks tend to be more dependent upon Medicaid to pay for and access such services, but there are limitations that we see growing because of the pay structure for covering that. So it really is a dilemma. And of course, because of the disproportionality of poverty among certain groups, like African American communities, men, women, and children, we're seeing incredible need in that population and other communities of color, along with everyone else, for those services, and another level of cultural competence that they also encounter when they do receive services, which is really not talked about enough. Culturally responsive treatment. It does matter that providers of mental health services understand the dynamics of families who are bringing a certain set of experiences and dynamics to the table in the treatment program, because what we end up seeing as an organization, sometimes unintentionally, are methods of working with and treating families that aren't really constructive and that really set a family in a worse course than when they started. So it's a lot to talk about with mental health services, and certainly something that we're seeing and feeling the pressure of locally and statewide. Medical doctor.
We have I think we had a question from this physician over here, and then we'll hear from this gentleman.
Thanks. Well, it's less of a question than a comment, Donna, given I feel like physician input has been invited. So
Yes.
I would say
You
this.
speak on behalf of all physicians I know.
Actually, I don't speak on behalf of my current or former employers, Wisconsin Academy, which I serve on the board of, or my wife, Cindy. But I do speak for myself as a physician with 40 years' experience, and proud to do that. I just say this. First of all, we should all stipulate to the fact that mental health is the canary in the mine of what could go horribly wrong with the rest of healthcare as well. We've never had better treatment for mental illness in the 40 years since I've graduated from medical school, nor have we ever had worse access to that treatment. And there is tragedy after tragedy every day in every community around this country. Some of it gets national attention on the news. Some of it is just blows families apart in individual communities. So that's something that we have to remain committed to and to solving. And there are solutions. Technology alone is not the answer, but there are technological solutions. Telepsychiatry is taking off, especially in rural areas where you don't have psychiatrists. There's a horrible shortage of mental health professionals of all types, psychiatrists and others. And again, it's the Jerry Maguire model or the Watergate model, follow the money. It's a horribly reimbursed service that the providers frequently get stuck holding the bag. And so a lot of great providers then, to survive and to be able to do work that they're proud of, and they're not proud that they're doing this, opt out of the system and only see people privately. And they opt out of those systems. So, I mean, we should all stipulate that and have to fix it. First of all, I'd like to say I'm an optimist. I'm a relentless optimist, and I would say that we have a lot of assets here, that all of these problems are not as bad in Wisconsin as they are in many other states, if not all. I mean, I know that the data's bad. The disparities are awful, and I'm not speaking about the disparities. They're unjust and awful, but we have assets here. And I'm so proud of the work that people like Lisa are doing. People like Sue Ann Thompson and the Wisconsin Women's Health Foundation are doing. And the model they're using, in my opinion, is the model we all have to use. We can't let the fact that we can't do everything stop us from doing anything.
Right.
That's what you did with the 60 women's names in Richmond, I think.
Yes.
And what you're doing here. You're not fixing every problem, but it's the starfish theory, right? We're gonna do it one at a time if we have to get it done. We have the Rural Wisconsin Health Cooperative, which is nationally recognized for what they've done to preserve access to health care in the rural areas of Wisconsin, despite the challenges. We have systems that are coming together to actually think about public health, and then we're refusing to let, in conclusion, I'd say, as people who provide healthcare services, we're refusing to let public policy idiocy stop us from doing what we can do. So we were on a path, where the payment models were going to change, and we're changing rapidly to the better, lowering cost, improving quality, holding us as the people who provide your healthcare services accountable for both the cost of care as well as the quality. And you can give high quality care. In fact, high quality care is actually cheaper. And Donna, some of your publications have spoken to that. Higher quality care, and Dave Kindig and others at UW, higher quality care is actually cheaper than lower quality care. And yet we had a secretary of HHS, Tom Price, an orthopedic surgeon from the, every time I do a procedure, I need to get a fee for service, blow up some of the advanced payment models. The good news is that's still going on. And it's going on despite of policy idiocy, and it is making, there are things going on that are gonna move us in that direction. But again, I congratulate the people who are not letting the fact that they can't do everything stop them from doing anything.
Okay, thank you.
The drug issue, but surfaced here, can you help me understand, if you look over time, has the drug and all of those things gotten worse over time? And what are the driving forces that, if it has, what are the driving forces that push people into that? And is that part of the medical approach to where we're spending money so they don't get into it in the first place, instead of the treatment after the fact?
Well, I mean, I would say that it's a very complex situation, okay? From the opioid epidemic, you've had a movement within medical training that was basically trying to put a priority on young physicians in the making and score them on how well they manage their patients' pain, okay? And so, there are medicines, opioids, that can help at least for acute pain. I don't believe they're effective long-term. And so as the medical profession started prescribing more, and I believe there's a genetic component to this too, where some people, my mother was allergic to opioids. She couldn't take them later in her life. So others can take 1 or 2 pills and all they're thinking about is when 5 o'clock rolls around, I can take that 3rd day pill because they have that huge tug. And so the medical profession does have some culpability in the education in terms of and quite frankly, the pharmaceutical industry that's really pushing this stuff. They have some culpability in the opioid epidemic. Now, we have tools that have been developed to try to help physicians know if somebody's already been prescribed this. And Wisconsin is, I think, a leader in that. And we're seeing a lot of the large systems putting a huge effort. I know in Marshfield, Dr. Larson's our pain clinic has done a huge job in lowering prescribing. I think 85% reduction in opioid prescribing in the pain clinic. Up north, 70-some percent. System-wide, I think it's close to 50% reduction. That will have a preventive effect because there'll be less people. I mean, I talked about dental. We had tens of thousands of people going to emergency rooms where physicians who aren't trained to deal with their oral pain and swelling, and they can give them antibiotics. And I think there was a study recently done where about half of those people get opioids. And their basic problem, which is tooth decay, wasn't even addressed. So, it's like quality care value is better. In that case, you need to go to a dentist, but dentists won't take them. So what does a physician do? They've got a patient in pain, they got, swelling, and that can lead to, people have died from lack of a dental, because of infection progressing and sepsis and a whole bunch of stuff. So it's really complex. With meth, I think I call it like the second coming of meth in northern and western Wisconsin, because that was a home brewed thing, and the law enforcement community was able to get on top of that. They took they were able to track some of the material that goes into building that, and so we kind of had a handle on that. Kind of went away for a while, but then it started to being manufactured in a big way down in Mexico and other places, and now it's being imported in. And that comes in through, the western side of the state, and that's a bigger issue. As far as the speed, I had one of the tribal folks who works with addiction counselors said to me, and this was a number of years ago, but he said 3 years ago, 80% of my patients were, alcohol was the problem, and now it's 80% opioids. So it hit that fast.
Can I just I don't know if it's build on it or add maybe a different perspective to what you said, because absolutely there's a need, and it's very promising that we're seeing a change in prescribing patterns. At the same time, I am concerned about a narrative that develops, that there was some idea a few months ago, there was some effort by some to suggest that part of part of the opioid epidemic was caused by people getting more access to the healthcare system via increases in insurance coverage. And I just want to make it absolutely clear that that is empirically not a supported argument, that mixes up causation with correlation. And I can't get into it much further except to say that the people that, like Greg said, people who are showing up in the emergency departments at hospitals because they don't have adequate oral health treatment in the community and are uninsured and are getting prescriptions for pain management because they can't get adequate, proper treatment, that's a problem of lack of access and lack of insurance. And I just want to say further that, yes, indeed, perhaps overprescribing of opioids has been part of the problem, but opioid and synthetic opioids and other things is a very complex problem. Like the Case and Deaton study talks about this concept of deaths of despair. If it's not going to be opioids, if it's going to be meth, it's going to be some other thing. This is the drug du jour, but there's a whole lot of factors that have converged over the last several years that have created whatever is going on where people, and opioids happen to be the thing that is the thing being used right now for whatever reason to address whatever challenges and lack of other perceived options that people are feeling. So I guess my concern would be that we not say it's because medical overprescribing, that was the problem, and end it there.
I would add to that and start off by saying you've asked a very complex question that would take a long conversation to answer for everyone, but in talking about African American communities and the impact of drug use, the criminalization of drug use, in addition to, the drug under economy, has a huge connection with the history of disparity, inequality, social and economic, that has really been part of the African American experience since the end of slavery. And you really have to go that far back. People say, oh my gosh, you say slavery, that's taking it back. Why do we have to talk about that? if you want to understand the status and the state of African American families, communities, urban centers, you have to go all the way back to the origin of our life here in the Western world. And the whole pathway from plantation to end of slavery to Reconstruction, through all the, social changes in social inequalities of Black codes and legal attempts to really keep a class of people oppressed and starved of opportunity for a 400-year span of time, but in the most recent, over a 200-year span of time, 100-year span of time, depending upon where you start looking. And that whole experience and struggle to secure economic security and what that meant each generation, and the migration from the South to the North to find work. And for the brief periods that work was available, but then work disappeared after wartime, and with white flight and the movement of folks to different places and spaces, and the creation of ghettos. And that's kind of trying to summarize it in like a very short period of time, but there is a history of progression and a very clear and obvious path that is not mysterious or ambiguous to come to the conclusion of how and why did we create communities of despair, communities where there was the absence of economic activity, no base. So entrenched poverty that was passed generationally down from grandparents to children to grandchildren, and what the introduction of illicit drugs meant for communities like the former Cabrini Green in Chicago, which thank God was leveled and taken down, and communities like that around the country in large urban centers, where the death toll, not only from the use of illicit drugs like crack cocaine, which we know was prosecuted in the courts differently than powder cocaine, which creates another cycle of disparity with over-incarceration. You have people using the drugs who are dying. You have people selling the drugs who are dying in street wars, turf wars. And you have people wasting away in prisons over generations, whole families who progressively, each young man, the generation after generation, prison, because the economy that they knew and had access to wasn't the economy that you and I have access to. And understanding how do we create those pockets of real despair in our country, in urban areas, in my case of talking about it, but seeing the same despair in rural communities. The drug is different, what they have access to is different, but at the core of it is despair and perceived lack of opportunity. So you've got this circle of opportunity that people can see, and those of us in this room are in the middle, buzzing around. But there are real people who are still trying to break through the barrier of that circle, and there are families that for generations have never made it inside. And so when something comes available to you that numbs your pain and the reality of your circumstances, and you use it, it opens a quandary of issues. So we'd have to sit and talk for a long time, but I want to recommend a book, The Warmth of Other Suns. Who's read that? You read that book, The Warmth of Other Suns. I want everyone here to run to Barnes & Noble tomorrow and purchase
Or the
that,
library.
or Amazon.com, or the library. They're the cheap, free way.
Actually, go ahead.
And read that book, and it will illuminate to you the hows and the whys that don't really get explained in the quick news stories or the articles or the criminalization narrative that we attach to all of these phenomena.
If I can just amplify a little bit of what I think we all have been trying to say, deaths of despair, even though this concept is, that phrase came after in the last 2 years with Case and Deaton, deaths of despair have been happening for a very long time in this country. And it didn't start with the rural working class 2 years ago. But it's only started getting attention with the opioid epidemic and the economic downturn that's affected the rural working class. And we should ask ourselves, I think, why we didn't focus as much on the deaths of despair that occurred for a long time in other communities. But it's time now to focus on the deaths of despair that exist wherever they are, in whatever geographic region.
Yes.
And with regard to the opioid epidemic, the one thing coming out of this is finally we understand that drug use and drug abuse is a public health problem. It is not a criminal justice problem. And when it was another population that was struggling, it was a criminal problem. But now that it's a broad population, somehow we understand that it's a public health problem. Well, maybe now we can get progress that will benefit people wherever they reside. And that could be a good thing.
And not just deaths of despair. We should be concerned with lives of despair because we want to get them before they're dead. But, that's key. But just let it sit that there are people whose lives, we all have issues and circumstances and challenges in our life, and we momentarily may feel real despair. But imagine a life of utter despair and lack of opportunity, entrenched poverty, or entrenched issues that just feel and seem insurmountable. Those things are real. When you work in the social services sector and in community-based, you don't believe some situations. If someone was just to tell you, oh, this happened and they lost this, and then they got this issue happened and it set them back, and then they tried to get employed but they couldn't, and then their mother died, or then they had to take care of the children because this one passed away and there was no one left to take care of them, and that caused this overwhelming sequence of, these are real things that happen to people who we can't always imagine in our lives that these circumstances can be true. They're true. There is an entrenched underclass in our society that we've created as a society and that we have to uncreate as a society. And it isn't because people want to be or don't try to rise above those circumstances. There are real barriers.
I want to thank our marvelous panelists. We could go on for another half an hour, but we're not going to.
Okay.
We like to start on time and end on time, and we will have a little bit of time in the room for people who want to ask questions individually afterwards. We do need to be completely out of this space by 9 p.m., and I know you'll help us do that. So please help me thank Donna, Lisa, and Greg.
Thank you.
And thank you all for joining us here tonight at the Wisconsin Studio or Facebook Live. The recording of this talk will be on the Academy website next week. Please remember to join us for the next talk in this series. That will be at the Capitol Theater on March 20th for an exploration of the pursuit of happiness with Ann Strainchamps of Wisconsin Public Radio interviewing Richard Davidson on the Center for Investigating Healthy Minds. Thank you so much, and good night.